has a schedule for this year, and I think most of you know, my understanding is that OEMS changed a lot of I guess, the rules, and so the topics have been set, and a schedule's been laid out this year where we're kind of mandated to do certain topics. So some of the stuff that I'll be talking on this year, we've actually done over the last couple of years at some time, including this talk. But I think that everybody's been notified. We get email notifications. I'm doing 6 lectures, and then we're going to do 6 rotations through the stations for skill stations and different stuff. So, kicking off, it's hard to say 2017. I'm still writing 2016 on prescriptions, and they're bouncing back. But so we're going to start 2017 with a talk about stroke. So this, I think everybody knows somebody or knows of somebody that's had a cerebrovascular accident, had a stroke, and it can be devastating. Many people recover completely, some never recover. But around the world, it causes 10% of the deaths worldwide on an annual basis. Hey guys, before you leave, there's just a blank piece of paper, just make sure you sign. In this country, every year, it's the 4th leading cause of death, but it's the leading cause of disability. So people recover, but they may lose function, arm, leg, speech, whatever. So in this country every year, we know that there are about 800,000 strokes. 3/4 of those are first-time events, so about 600,000 people have a stroke for the first time. About 200,000 are recurrent episodes. Once you've had a stroke, there's a chance that you'll have another one at some time in the future. Men are at greater risk than women. Blacks are at greater risk than whites. Older, greater risk than younger people. In 2010, this was a $74 billion expense to the healthcare system. Now, I'm sure with the Affordable Care Act, I'm not going to get into that, but I'm sure that cost of $74 billion, that's a piece of data that's 6 years old. I'm sure it's much, much higher now. So you say, what is a stroke? Well, it's really, really simple. It's the interruption of blood flow to a part of the brain. And that interruption is either due to blocking an artery or a blood vessel rupture. So it's real simple. There's a certain part of the brain that's not getting blood, and that blood's either being blocked by a blood clot or the vessel ruptured, and those neurons are getting compressed and are not getting blood flow. So what are the risk factors? We're going to talk about a whole list here for a few minutes. There are some risk factors that we can't control. Our age, you're blessed to be a year older every year. But as we get older, our risk of having bad things happen and cardiovascular disease increases. Our family history. You can pick your friends, but you can't pick your family. And it's the same way with your family history. Those genes, those are the cards you were dealt. And if you know in your family, if there's a strong family history of various illnesses, of hypertension, of stroke, of heart attack, that's something that you should know. We should all know our family histories related to cancers, for instance, and we can take action on some prevention there. Our race is our race, our sex is our sex. Those are the cards we were dealt. And then, just we mentioned a few minutes ago, if you've had the misfortune of having a prior stroke, a prior transient ischemic attack, or a prior heart attack, then you have a certain risk factor for that happening again. Now, there are some things that we can modify or we can change. If you've got high blood pressure, you can treat that. And we used to say that 140/90 was kind of where we wanted blood pressure to be, and that's still the number. If you go to do a commercial driver's license, a DOT card, or in the fire service, we're talking about annual clearances, that's still the number that's out there, but the fact is most of the literature and most of your internists and family docs are wanting that blood pressure down lower to where, the old 120/80 is considered to be the number we want everybody to be at. And so, again, you take high blood pressure and where your blood pressure is at and take that in context of other risk factors. If that's your 140 over 90 and you're not a smoker, and you're not a diabetic, and you're fairly active, yeah, you kind of weigh that. But if you've got a pressure of 150 over 90 and you smoke and you're diabetic, and you go, yeah, we're going to get aggressive about wanting that blood pressure down. Smoking is modifiable. I think for those who do or have smoked, you know that it's not just as easy as saying quit smoking. Nicotine is probably the most addictive substance we know, way worse than cocaine, way worse than opiates. And it's because nicotine acts on our central nervous system. And the average person, I've seen the data, it's either 5 times or 8 times they try to quit before they're successful. And there's all kinds of adjuncts, but if you smoke and you quit, literally the day you quit, your risk starts dropping off for cardiovascular events. And 3 to 5 years out, being off tobacco, being off cigarettes, your risk is getting close to someone who never smoked. So smoking is modifiable. It is probably the most difficult on this list, but it's probably the most important on the list. Diabetes, we've talked in every single talk that we do, regardless of its gunshot wounds, if it's strokes, if it's heart attacks, if it's infections, whatever it is, diabetes is a confounding problem. Blood sugar problems make everything worse. And so what is considered diabetic? Well, a couple factors. You look at what's a fasting blood sugar, and we want it to be less than 100. You know, what's the blood sugar after you eat, and depending, 120 or so. So 80 to 120 is considered normal range. Now we look at hemoglobin A1C. So if I drew a blood sugar on everybody in this room, that's a point in time right now where your blood sugar's at. And that really depends on when you ate last and kind of the day you've had. But if we draw hemoglobin A1C, that's looking at an average over the last 12 weeks. It's a very, very useful number. And so hemoglobin A1C of 5.7 to 6.4 is considered pre-diabetic. Less than 5.7 is entirely normal. Above 6.5 is considered diabetic. And so if you go through your annual physical and your hemoglobin A1C is 5.8 or 5.9, what that's telling you is your blood sugar is running a little higher than we like all the time. And how do you modify that? You can modify high blood pressure, you can modify diabetes, you can modify some elevated cholesterol, particularly good and bad cholesterol, with exercise. And it's not a matter of being a marathon runner. It's a matter of doing something such as fast walking that just simply gets your heart rate up 120, 130. It keeps it there for 15, 20, 25 minutes. If you do that 4 or 5 days a week, just brisk walking, get your heart rate up, keep it there for 15 or 20 minutes, over a period of 6 months, you'll see not only your weight come down a little bit, but your blood pressure come down, your total cholesterol come down, your HDL come up, and your blood sugar will come down. So really, it's modifiable factors of weight and a little bit of exercise can really make a big difference on blood pressure and diabetes. Now, manageable risk factors, if you've got carotid artery disease, well, how do you know you have it? You have a physical, and your doctor hears a whooshing sound called a bruit in your neck, and you get tipped off, maybe you ought to have a Doppler, and we see some obstruction. Well, there's a point at which that can be fixed. Peripheral artery disease, kind of the same way. Atrial fibrillation, we've talked about in talks, is an irregularity of the top part of the atrium of the heart. And when you go into atrial fibrillation, you lose about 25% of your cardiac output. But more importantly, as though the top part of your heart sits there and just kind of quivers, blood isn't pumped through efficiently, and the blood can sit and you can develop clots. And those clots then can get flipped off and go to your brain and other places. So people that are in atrial fibrillation, we manage not only the rate and keep their rate controlled, but the vast majority are on blood thinners. The old one being Coumadin, then we've got that whole group of new ones, the Xareltos and the Eliquis and things like that. But atrial fibrillation is not something to be ignored. We talked a little bit about high cholesterol. Cholesterol above, we want everybody's cholesterol to be below 200. But when you look at that, the important part is the good and the bad cholesterol. The good cholesterol are your HDLs. Your HDLs are raised by exercise. There's some evidence that drinking a glass of red wine on a regular basis raises that. Exercise lowers the LDLs, the bad cholesterol. So it's not only the total cholesterol, but it's the HDLs and the LDLs that are important. We talked about diet, manageable risk factors. We, depending on our jobs, most of us are on the run and we eat a lot of fast food. And so diet modification and watching, the fats and the fried foods that you take in. We talked about physical activity as an important factor. And once again, for all these factors that modify risk factors for stroke and heart attack, it's not a matter of having to turn into a distance runner or triathlete. It's a matter of finding 20 to 30 minutes 4 or 5 days a week to do something aerobic. And we're not talking about lifting weights, going to the gym. We're talking about something fast walking, slow running, treadmill, step mill, whatever it is that gets your heart rate up and keeps it there for 20 or 30 minutes. And that's really all it takes. So what are other risk factors for stroke? Well, living in the stroke belt, which is where we live, the southeastern United States, that's we're in the kidney stone belt as well. I'm not sure anybody has the data, whether it's our diet or the heat or what it is. Socioeconomic factors, people who live in lower socioeconomic factors are at risk for a lot of things. Alcohol abuse obviously puts people at risk for stroke, and drug abuse, particularly cocaine and amphetamines. So when we talk about strokes, we talk about ischemic or hemorrhagic. So basically, an old saying, dry stroke, wet stroke. Ischemic stroke, there's no bleeding, and that's the vast majority of our strokes. And the hemorrhagic strokes are broken down into subarachnoid bleeds and intracerebral bleeds, or bleeds within the brain matter. So an ischemic stroke is an obstruction of blood flow to a part of the brain. And you either have a thrombosis or an embolic event. So a thrombotic event means that an artery in the neighborhood of the brain is blocked by a blood clot that formed there. So atherosclerosis, where have you heard that word before? That's the same process that goes on in the heart. You get hardening of the arteries, get a cholesterol plaque build up, the vessel the inside lining swells and ruptures, so now you've got an irritated place that a blood clot forms. Now you've got a blockage of everything distal to that. Vessel dissections. What's hypercoagulable state? Certain illnesses tend to make our blood clot. If someone walks in and they're otherwise healthy and all of a sudden they develop a blood clot in their leg, yeah, I'm going to look and find where the clot is and take care of that. But the next question is, why did that happen? First thing you think of is cancers. And so there are things that cause the blood to be hypercoagulatable, or it tends to clot faster. And so that can predispose you to stroke. And then there are some infections, particularly the old infection, syphilis, the great mimicker, which can cause or cause vasculitis, which is an inflammation of the vessels. So thrombotic events, atherosclerosis, some other things cause a clot to form at a certain point and obstruct flow on downstream. Embolic events, the clot comes from somewhere else, like the heart, like an atrial fibrillation. So a person goes into atrial fib, the heart's not working right, clots form, one of them flips off, goes upstairs, and finally goes until it reaches the narrowest part of a vessel, stops the flow, and we have a stroke. When that happens, blood flow's obstructed to a small area, hopefully a small area of the brain. And those neurons at the core of that area begin to die. They have 4 to 6 minutes. They require oxygen, they require glucose. They're not getting either of them when that artery is blocked. And then you have an area around there that the neurons are stunned. They're getting blood flow from other areas, collateral circulation, but they're not getting the blood flow they're accustomed to. So that's called the ischemic penumbra. But bottom line is there's an area that artery feeds, it's blocked, those neurons are dying, they die in 4 to 6 minutes. And the area around them are neurons that are kind of stunned because they're not getting the blood flow that they like, and the amount of oxygen they like, and the glucose they like. And that's the area that's salvageable. There is a condition, the emergent large vessel occlusion. So we talked about small arteries getting blocked. This is when a larger vessel gets blocked. And these are the catastrophic strokes. And these are the ones that the treatment is best, where not only do they get clot buster drugs, but they go to the lab and they actually have someone go in there with the catheter and start recovering clot and get the vessel opened up as quickly as possible. So when we talk about, we talked about ischemic strokes. Those are the ones where there's no bleeding, but a clot blocks the vessel, where the clot formed right there, it came from somewhere else, causing blockage of blood flow to a portion of the brain. The other kind of strokes, which are less prominent, they're only about 20% of the strokes, but they're more catastrophic, are intracerebral bleeds and subarachnoid bleeds. We could do an hour lecture on each of those. An intracerebral bleed is typically associated with a little older age group with hypertension, particularly uncontrolled hypertension. So people have gone for years and just let their vessels be pounded by high blood pressure. Tends to be worse in blacks and Asians. Tends to be worse if the person uses tobacco, not only smoking, but smokeless tobacco as well, and alcohol, if they've had prior strokes, and cocaine use. So what you see there is the patient, when you get the CAT scan, there's an area in the brain where there's been a small amount of bleeding. Well, how does that affect the neurons? Well, first, when the vessel ruptures, then blood flow is interrupted. But more importantly, that blood is being pumped out and is forming an area of pressure that's compressing those neurons. And as they compress, they don't get blood flow, and 4 to 6 minutes they die. The other category of hemorrhagic strokes are subarachnoid bleeds. And these are pretty classic many times in their presentation. And they're typically due to aneurysms. Some are due to what we call AV malformations, that is, vessels that have malformed since birth and suddenly rupture. But aneurysms, the whole thing of subarachnoid hemorrhages is something we learn in emergency medicine, because we expect a fairly typical presentation. These are folks that are sitting here just like us, and they're feeling well, and all of a sudden the classic is what we call a thunderclap headache, where headache doesn't build up all day. It hits, and it's as bad as it's going to be as soon as it starts. And those people all of a sudden they get this terrible headache, they get nauseated, they throw up, and many times they pass out. And they're doing that because an aneurysm just ruptured somewhere in their brain, and now is increasing intracranial pressure, and neurons in that area are starting to get compressed and die. Aneurysms occur in about 2 to 3% of the population. We used to think that, we came with those from birth and they've been there forever, and that's not the case. What we found is that most of them are acquired. In other words, they develop as we age, and they're developing because we drank too much or we used tobacco too much uh, over time. And if you do an arteriogram, you'll find them in somewhere between 1 and 3% of the population. The question is, why do they rupture when they rupture? It used to be thought that, well, you're under stress, you jack your blood pressure up like during exertion, and maybe that's what causes it, and that's not thought to be the case. So, as I said, subarachnoid bleed occurs, and it's classic. The patient gets a sudden headache, they get nauseated, most of the time they throw up, and many times they pass out. And that's a subarachnoid until proven otherwise. How do we diagnose those? Well, those are the ones that we get in, and interestingly, many times a CAT scan for a small subarachnoid bleed can be negative. And now it can be a diagnostic problem. These are the ones we're taught in emergency medicine that do a CAT scan, and if you're thinking subarachnoid bleed and that CAT scan is negative, the next thing you do is a lumbar puncture, a spinal tap, and you're looking for blood in the cerebral spinal fluid. And that has its own set of issues. But a CAT scan might miss a subarachnoid bleed if it's delayed in getting done. If the bleed was small and the cerebral spinal fluid's being made and circulated all the time, it may clean out the blood was there. If it's a small bleed, if it's an old scanner, the new scanners are lots of slices, like 64 slices versus 16 slice or 4 slice machines in a certain distance. So the older machines aren't as sensitive as the new ones. The older eyes of old physicians aren't as sensitive as some of the new ones. But the other thing is, if the patient is anemic and the blood's thinner, it may not show up as well on a scan. So there are some things where this can be missed on CAT scan. And that's why if we're thinking it and we don't see it on scan, we're kind of obligated to then do a lumbar puncture and look for blood in the cerebral spinal fluid. The problem there is lots of taps are traumatic and get blood in them. So it's not an easy diagnosis in some cases to make. The problem with subarachnoid bleeds is the original bleed's bad enough, but there's a high incidence of a rebleed within 72 hours. So this little aneurysm, this little weakness or bubble in the side of an arteriole or an artery burst, and it bled, and it caused the symptoms, and then the bleeding clotted off. But now, because of various factors, you get a rebleed, and the rebleed can be a real problem. So these are the folks that get put to bed many times, either get taken to surgery or get taken to the interventional cath lab and get coiled or procedures done to clip that aneurysm because the danger is with the rebleed. So we just talked a lot about this, that hemorrhagic stroke is typically due to a blood vessel rupture, which is an aneurysm is a weakened area of a vessel. But blood accumulates, causes pressure, causes those neurons to be without oxygen, and cause those neurons to die. The patients of hemorrhagic strokes tend to be younger, particularly the subarachnoid bleeds, and carries a lot higher mortality. In 30 days, the mortality from a hemorrhagic stroke can be between 1 in 2 and 1 in 3, 30 to 50%. So it's a pretty serious event. So we talked about ischemic strokes, we talked about hemorrhagic strokes, and a little bit about subarachnoids. Transient ischemic attacks are basically mini strokes or warning strokes. It's interesting that the definition back in the 80s, TIAs were defined, or the 70s, TIAs were defined as stroke-like events that resolved in 24 hours. And then we even went as far as we had something called a ischemic neurologic deficit, RIND, where they went out 72 hours. All that's going by the wayside because what we now know is that a TIA is a temporary transient episode of dysfunction, whether it's affecting a focal part of the brain or the spinal cord or the retina of the eye, that resolves without acute infarction. What that's saying is acute infarction means cell death, just like myocardial infarction, cell death. Angina to the heart muscle doesn't die. It hurts. Say you walk up a flight of stairs and you get chest pain, you sit down, the load on the heart gets better, the load goes away. So that heart was ischemic and it hurt, but that muscle didn't die. When you have a heart attack and the vessel's blocked and you don't get to the cath lab, that part of the muscle dies. Same way in the brain with a TIA. This is caused by a clot which is rapidly dissolved and function comes back. So there's no permanent damage. But a third of these people go on to have a stroke sometime within a year. So TIAs are to the brain what angina is to the heart. It's kind of a warning sign. And TIAs they're problematic. First time TIA comes to our clinic or comes to the emergency department, those patients need admitted because they're at risk for something more permanent and bad happening in the near future. So of all the people that have strokes, so those 800,000 people that had strokes, 600,000 of them are new, somewhere between 12 and 30% of those people had a TIA at some point before their stroke. So 200 to 500,000 people a year have a TIA. 3 or 4% of them don't get care. So think about that. So if there's 500,000 people having a mini stroke, 20,000 of them don't even seek care for it. That's pretty amazing. The highest risk of stroke is in the 24 hours after that TIA. So someone has all of a sudden a facial numbness, arm numbness, or loses speech, and they get better in a few minutes and they kind of blow it off. Within 24 hours, they may have the real deal, and certainly somewhere like 1 in 5 have a stroke within 90 days. At 1 year, 12% of those people will have died. At 10 years, almost half of them will have had a stroke or a heart attack. So these things that we used to call mini strokes and people got put on aspirin and that was it are no longer. They're admitted to the hospital, worked up like a stroke, carotid Dopplers, echocardiograms, looking for preventable causes, looking at all the things that might be modified, like their blood pressure, like their lipids, so forth. But TIAs share exactly the same causes as ischemic strokes. The fact is, they just get better in a few minutes, and there's no permanent damage. So it can be a tough diagnosis for a physician. A patient comes in and you say, geez, are they having a stroke, or is this someone with a low blood sugar that can have these same symptoms? Seizures with something called Todd's paralysis, where you get one side of the body is weak. Is it Todd's paralysis? Is it a stroke? Complex migraines can present with stroke-like symptoms. We had a case within the last couple of weeks. Patient came in, really didn't have stroke risk factors per se, but was having what sounded like TIAs. In fact, MRI showed it was multiple sclerosis. So it can be a tough diagnosis, but it's not one that we can ignore. So when we talk about stroke, we talk about recognizing a stroke fast, F-A-S-T. Face drooping, arm weakness, speech difficulty, and it's time to call 911 because time is of the essence. And we look at the brain, and we look at the various lobes of the brain, and we have the frontal lobe, the parietal, the occipital, the temporal lobe, and then of course the brainstem, which is where respiration and our sleep and wake cycles come from. The cerebellum is where most of our coordination comes from. And it really depends on what part of the brain is affected, depends on the stroke symptoms. So when we talk about the brainstem, we're talking about breathing and sleep. The cerebellum's coordination and balance. The frontal lobes are our judgment, kind of our personality, who we are, our ability to solve problems and and motor skills. Parietal lobes, our sensation and our fine motor skills like handwriting. The temporal lobes are our memory, how we store stuff, and hearing. And the occipital lobes are visual processing. So each area of the brain has a function, and one side of the brain is dominant for us and the other is non-dominant. But the area of the brain affected defines the symptoms. So the blood supply to the brain comes through our carotid arteries, which go up in the front, and our vertebral arteries, which go up in the spinal canal, up through the vertebral canal. So there are 4 arteries, 2 carotids, 2 vertebrals, which come up, go and form a circle, which is called the circle of Willis, off which branches more arteries, such as the anterior cerebral artery, the middle, and the posterior cerebral artery. Our carotid arteries come up and form external carotid, internal carotid. The externals give blood supply to the face and the scalp. The internal carotids get blood to the front 2/3 of the brain. So an occlusion of the carotid artery can cause numbness, weakness, paralysis on the opposite side of the body. The anterior cerebral branches off the internal carotid, gets the frontal lobes. So our logical thought, our personality, our voluntary control of our legs all come from our frontal lobe. So blocking one of the anterior cerebral arteries will cause loss of voluntary muscle use of the opposite side leg, for instance, or leg weakness. The most common artery blocked in stroke syndromes is the middle cerebral artery. It's the largest branch of the internal carotid. And it's primarily motor and sensory for our face, our hands, our arms. Our speech can get hit there. So an occlusion of the middle cerebral artery, a big stroke of the MCA, causes sensation loss in the face, the arms greater than the legs, and speech loss primarily. Many times, posterior cerebral artery, a lot of people don't know that something happened. They may get a visual field loss, they may get a little hallucination or kind of mix up their words, a lot more softer symptoms. So when we talk about symptoms of stroke, what are some general symptoms? Well, numbness of the face, the arms, the legs, usually one-sided, especially one-sided. So someone, you get called to the scene and they're talking about, I got numbness in my arm and my leg and kind of down the side of your body, you've got to think it's a stroke on the other side of their brain. Confusion, all of a sudden someone just can't get the words out, or they just can't seem to understand what is being said. Visual problems. Interesting one here is something called amaurosis fugax, and that comes from the internal carotid and feeding basically the eye, the ophthalmic nerve, is you get an occlusion of the artery feeding that, and you get a shade. Literally, you're watching the screen, all of a sudden it's like someone pulls a shade over the eye, and a few minutes later the shade goes up. That is consistent with a TIA. Coordination, particularly if the posterior brain, the cerebellum is involved, trouble walking, dizzy, maybe vertigo, lack of balance. We talked about the subarachnoid and headache, that sudden onset headache, nausea, throwing up, maybe unresponsive, so that is more consistent of a hemorrhagic stroke, a bleed. And so when we talk about stroke syndromes, someone comes in with opposite side weakness of the legs more than the arms, and they can't quite write, and they're slowed responses. We're thinking of there's an obstruction in the anterior cerebral artery, and maybe they can't use their arm. We think of the middle cerebral artery, and posterior cerebral artery, light touch, pinprick, they just don't have sensation. The pins and needles sensation could be associated with that. When we talk about vertebral basilar, which is kind of the back and base of the brain, dizzy, vertigo, can't walk, they stagger to one side, they might have limb weakness on both sides. And cerebellar infarct, our cerebellum's where our coordination comes from. These are people that just all of a sudden they fall down, or they have just suddenly get bad room spinning vertigo, and they may have neck pain, they may have nausea. Interestingly, CAT scan is not a real good study for that. An MRI is a better one. CAT scan just misses that area. So how do we gauge these in the field, and what's the importance? Well, there's really two stroke scales that get used. One's the Cincinnati pre-hospital stroke scale, and it looks at facial droop, arm drift, and slurred speech. So patients sitting there, you ask them to smile for you, and they smile, and it's symmetric. What you're looking for is they smile on one side and it's weak on one side. So you're looking for facial drooping. The other is arm drift. You ask the patient to hold their arms out, palms up. And many times you say close your eyes with that so they can't watch their arm. They can sit and watch, but maybe one arm drifts away. They can't control it. Or even worse, they put their arms out and one arm falls. So facial droop, arm drift, that's looking for the arm to drift to the midline or inability to hold it up, and then slurred speech. You can use any terms you want. In this pre-hospital stroke scale, they use "you can't teach old dog new tricks," and it's a beautiful day in Cincinnati. I've never seen a beautiful day in Cincinnati. So you can have them say that and see if they slur their words. And if so, you're positive for stroke. The Los Angeles score uses points, and basically they're looking for a facial droop. So again, smile for me. All right, if there's no facial droop, that's 0. Hold your arms out. All right, it drifts, they get 1 point. If it falls, they get 2. And they use then grip strength, looking as is the grip weak on one side, or can they not grip on one side? And so if you've got, they didn't have any facial droop, but they've got a little bit of drift, or they rapidly fall, let's say they get 2 points and they got a weak grip, it's 1 point, so they got 3 points. Then 1 to 2 points is positive for a stroke. 4 more points is a high probability of that big vessel occlusion that we talked about early on. So in our state protocols, Protocol 28 is suspected stroke. The take-home tonight is the time of onset of symptoms. And the key is to remember is 5 hours. So what we really need to know is, when did this start? If someone wakes up from sleep with these symptoms, we have to consider that we don't know the time of onset. On the other hand, we're all sitting here, and one of us right now, all of a sudden, I don't feel right, and gets facial droop, an arm drift, and slurring speech. We know it's 7-11. And that's what we want to know, is the precise time things start, because that really guides therapy from there on out. So finding the precise time of onset of symptoms, and again, if they woke up with them, we don't know when they started. And this is one where we want our scene time to really be limited to 10 minutes or less. If their time of onset is under 5 hours, then we want to transport to a stroke-capable hospital. We want to get a fingerstick glucose, make sure their sugar's fine. We want to get a 12-lead while en route, make sure they're not in atrial fib. We want to get IV access. We want to monitor them. But if it's under 5 hours, we're going to a stroke-capable hospital where we can hopefully do interventions. If it's over 5 hours, we're going to do all the same stuff, but we can go to any emergency department. Because if it's over 5 hours, they're not going to get thrombolytics. It's outside that time window. So once again, we get the fingerstick sugar, we get the 12-lead, we get the IV access, we monitor, but the over under 5 hours really defines where we go. So what's a stroke-capable hospital? A stroke-capable hospital has CAT scan available 24 hours a day. They're willing to move patients around in that CAT scanner to get that stroke patient in. They're going to take that patient, we call, we're coming, They're taking us regardless of their bed status. They're able to get the patient to the scanner, they're able to evaluate the patient, and they're able to administer TPA if it's clinically indicated. And then they're going to give feedback to the system. So we talk about stroke-capable hospitals. Well, Duke Regional, UNC, Danville Regional are all stroke-capable hospitals. Person is going through the process to become a stroke-capable hospital. And again, the criteria is pretty simple. You've got an emergency physician, you've got to have CAT scan available 24 hours a day immediately, and once you've got that CAT scan result and it's red, and that's the key, CT's got to be red, there can't be any bleeding if you're going to give TPA, then you got to be able to give TPA. And then that patient from a community hospital such as Person could be transferred, but the whole point is getting the thrombolytics, which is the only really thing that we have to treat an ischemic stroke with. Duke and UNC also do the endovascular procedures we talked about for that big stroke that may require thrombolytics as well as an interventional procedure, an endovascular procedure. So what are current treatments for an ischemic stroke? TPA, go in, you get the TPA, then a specialist, an interventional radiologist, for instance, goes in, puts a catheter in, tries to remove the remainder of the clot, and the other treatments are conservative management and physical rehabilitation. Now, giving TPA for stroke is probably one of the most stressful events for an emergency physician, because we just talked. It's like there's a lot of things that mimic stroke. We're trying to pin down when this started, and it's not without side effects. So the American Academy of Emergency Medicine was one that wasn't real hot, real keen on making this the standard of care, because 6 of 18 people will recover regardless of what we do. 8 of 18 recover over 3 months with no disability. So you got an ischemic stroke, 4 out of 9 people will get better and completely recover regardless of what we do. But let's say that we've determined that they're within the window, they're going to get thrombolytic therapy. And if we give thrombolytic therapy to 18 patients, one of them is going to bleed. Now, we knew that when we were giving it for heart attacks. There's a chance that you're going to have a stroke with this medicine I'm giving you. It's a chance. It's the same way with strokes. You're having an ischemic stroke, there's a chance I'm going to turn it into a hemorrhagic stroke. And that chance is 1 in 18, so about 6%. You willing to take that risk? Well, that depends. I might be. But the fact is, if you bleed, you got a 1 in 2 chance of dying. So it's, as we used to say, it's a sphincter tightening experience when you're giving TPA to a stroke in an emergency department and hoping that this guy doesn't bleed on you and subsequently die. And so you really have to look at where the complications occur, and they occur in older people over 70, and they occur in severe strokes or glucose is out of control. But TPA is the best therapy that we have for someone who comes in with an ischemic stroke. They get a CAT scan, the CAT scan is completely normal, there's no bleeding, all right, we give them the TPA. And many of them then very quickly get better. And it is the standard of care. But we have a limited time to work with, and so that's why it's important that we pin down that when those symptoms started. And it's something important for first responders as well as advanced providers to nail down of, hey, this is when this happened. So there are a lot of lookalikes for strokes, and they need sorted out. So things like global amnesia. This is something where someone all of a sudden, usually in their 50s or 60s, it's not like a broken record. They can't process any short-term memory. They haven't had a head injury. They haven't had a seizure. They're not crazy. They don't have any psych disorders. They don't have any motor or sensory deficits. They just can't remember what happened a minute ago. And they just keep asking the same questions and so forth. And there's some association with increasing age and recent emotional stress and recent intense physical efforts, but you're thinking, gee, is this patient having a posterior circulation stroke and they can't remember things, or is this global amnesia? Don't know. Bell's palsy we see all the time. Patient comes in, many times they woke up with it and say, I think I had a stroke, and they're drooling out one side of their mouth. And this comes from an irritation of the facial nerve. The facial nerve comes out in front of the ear, and it branches out, 5 branches as I recall. But what it does is, many times it's due to a virus, an irritation of this nerve. And so not only can you not, when you smile, you got a weakness on one side of the eye, but you can't close the eye. And so that's what's most annoying to the patient. They can't close that eye. They can blink one side, but they can't completely close the other. And you ask them to wrinkle their forehead, and they can wrinkle one side, but not the other. And so that's Bell's palsy. These folks get put on, usually, big doses of steroids, and most of the time we give them an antiviral like Valtrex or acyclovir. But it can be problematic because their eye dries out and they have to tape their eye closed at night and put eye ointment on to avoid getting corneal injuries. Low blood sugar, it can mimic a lot of things, and particularly in the old, neurons got to have sugar and they got to have oxygen. And you can have great circulation, but if you don't have enough sugar in there, you're going to get neurologic dysfunctions. And so you can get stroke-like symptoms, which is why we check when we go on scene and we're talking, we think we have a stroke, while everything else is going on, someone needs to be checking the sugar, because we want to know that these symptoms we're having now are not due to a sugar of 20 or a sugar of 1,000. We want to know that where we're at. We talked about seizures a little bit ago, something called Todd's paralysis. Patient has a seizure. Their residual is in the postictal period. They may have numbness or loss of use of one side of their body. And it can be a motor. It can affect speech. And now you're sorting out, okay, they had a seizure. Now what do we got? And complex migraines. You've got a 24-year-old college student comes in and they're having slurred speech and visual symptoms and maybe some numbness in an arm or a leg, and they have a history of migraines and they got a headache. It's like, oh, well, you get the migraine better and symptoms go away, you pretty much got an answer, but again, it's confounding. And cervical artery dissection is something that you don't see a lot of, but patients in a motor vehicle collision or they're in a fight and they get struck in the neck, and all of a sudden, within a day or two after the injury, they get stroke-like symptoms. Well, they got whacked in the neck, and now they've dissected a carotid artery. Yeah. And so if they're under 45 and they have a stroke, 1 in 5 of those are due to injuries to the neck. There's been some association with patients with chiropractic manipulation of the neck having vascular injury. So stroke, it's a devastating illness. And again, it's the illness that causes a huge amount of disability. Same risk factors as heart disease. Many of those are modifiable. The thing that we need to pin down in what we do as first responders and ALS is determining the time of onset of symptoms, because that's going to direct where we go for therapy. And that's it. Questions? Well, thank you all for coming out. If you've not signed the sheet, put your name down. I'll get that over to Glenn tomorrow.